Okay, so hopefully you have a better understanding now of the levels of pain control and how we can potentially start to target some of those with our modalities. What we're going to kind of end on now is we're going to focus on common pain syndromes. So most of what we've been talking about so far has been acute pain. And what do we do when we sprain our ankle and need to deal with that pain, and how do we experience that pain? But like we said, pain is very complex, and so there are actually these pain syndromes, and we've talked about some of these in 206 already as well in med topics, right? Of what are these kind of vague pain syndromes that we see. Well, the most common one that we're going to end up dealing with is definitely chronic pain. And chronic pain is just pain that can persist long after the initial acute injury has been repaired. It's something that extends beyond the normal course of the injury or illness. It's pretty debilitating. It often can have a big effect on a person's life, physically, psychologically, socioeconomically, if they can't work. Lots of consequences to this. And what happens is the pain either extends beyond that normal course, so there's not that nociceptive activity anymore. It might have actually started in response to that real activity, but now you have a pain response in absence of any actual damage. So the pain actually becomes the pathology. It's often really difficult to treat, and often treatment is very unsuccessful, and it can lead to like depression. It can definitely have, again, these kind of long-lasting effects on individuals, and actually usually, again, something you talked about in med topics, depression can actually have usually symptoms of chronic pain, and chronic pain can lead to depression. So it's really a cycle that someone can get stuck in as well. Chronic pain can often accompany chronic conditions like arthritis. And the issue with that is you can't get rid of the pathology, right? These chronic conditions don't heal in the same mechanism. They continue to have chemical irritants. They continue to be problematic. And so then the treatment really becomes more, you tried the primary, right? You tried to actually heal the area, but the arthritis isn't going away. So unless you have surgery and do some of these other things that also don't have great outcomes, okay, we don't have much use on the primary. There's not much primary pain control that we can do. So the focus becomes on the secondary. So how do we just kind of help with the perception of the pain? Because stimulus is always going to be there in some of those chronic cases. If a disease is not identified as the source of the chronic pain, there might be issues with neuropathic chronic pain, which is pain essentially that is originating in the nerves itself. So there's an abnormal signal being sent on the nerve without any stimulation. So it can be caused by abnormality in either the peripheral nerves and neurons or in the central nervous system itself. And again, like I said, there's very little understood. This is an area that continues to get a lot of research. Chronic pain is a huge issue in our society and in our medical and healthcare systems. So it's difficult. It's difficult when pain gets to this point. So ideally, we'd want to take things from the acute side and make sure that they heal properly, and we go through the inflammatory process appropriately so that we don't get stuck in this chronic pain cycle. Another type of pain is referred pain, and this is pain that originates from an inflamed structure, but that inflamed structure is somewhere else than where we are sensing the pain. And that's really important. It's not that the pain is felt in this area, it's that's where our perception of the pain is coming from. Okay, most often it's we talk about referred pain with the organs and the visceral organs specifically, so thinking like the spleen and the heart and things like that. So you guys have all taken CPR, you know that heart pain, right, someone having a heart attack, tends to go to the shoulders and go down the arm. Spleen pain tends to go to the left shoulder. There's lots of different areas that have that referral. And actually, it's super interesting of why referred pain happens. And again, you can get into this more in other courses if you'd like, but it has to do with fetal development. And so when the fetus was forming, these organs were actually near these areas of the body and that skin and that contact, the cutaneous nerves. And so those nerves formed in those areas near each other. Well, as the fetus develops, the organs kind of move into the abdomen or into their cavities, but the nerves that were created are still connected. And so that's why we sense that pain in that area of the skin and the area for a muscle or for a organ that is somewhere completely different. So whenever you have patients suffering from pain of kind of an unknown origin, referred pain needs to come to your head. Okay, so yes, they're having shoulder pain, and us as athletic trainers automatically want to think orthopedic and that is shoulder involved, but could there be other things? So you spent a lot of time in med topics, right? Like, don't miss those other things. What are these kind of zebras that could be out there that could be causing this? So referred pain is something to keep in mind. So a really thorough history and evaluation is needed. We can't be in a hurry when someone has referred pain, because we'll just think it's an orthopedic thing and we'll focus on the shoulder and we'll miss the fact that it could be the heart or the spleen or something else. Usually that area of the skin will also have some hyperalgesia, so stimulation of that area might be hypersensitive as well. So these are some typical referred pain that your book goes through. You know, again, the right kidney pain, that doesn't seem all that much referral, right? Because that is where the right kidney is located. But it's the fact that we feel it on the skin or kind of on that surface when it's really down inside. We can't really, our brain and the processing centers, because of how the nerves were developed, can't really ascertain pain inside the body like that. We almost always have to associate it with a cutaneous area. Next type of pain is peripheral nerve root or spinal cord pathology. So if the nerve itself becomes damaged, either in the periphery or in the spinal cord itself, what does that mean? Peripheral nerve damage normally destroys all the fibers in the nerve, both the sensory and the motor. So usually get a loss of function distal to that side of damage. So if we damage our radial nerve, we're going to have loss of sensation along the radial distribution. Okay, so usually kind of the thumb side of the hand, as well as then we're going to lose function of those muscles that were innervated by the radial nerve. And so again, a lot of thumb action, some of our extension, okay, the extension of the tricep, things like that are going to be affected depending on where the peripheral nerve was hit. So if the peripheral nerve was damaged more in the forearm, the tricep is going to be fine. It's going to be everything distal to that. If it was up in there, up in the tricep, it's going to go more distally from there. Spinal nerves are a little different. So spinal nerves and the dorsal root nerve damage creates a pattern of sensory loss, and that turns into the dermatome pattern. So we've talked about dermatomes in both techniques and in medical topics. That dermatonal pattern can tell you a lot that it starts and is initiated at the spinal level, either in the cord itself or in the spinal nerves as they come off. So again, if you think back to that picture of the spinal cord that we had a couple videos ago, you see the two kind of roots coming off the spinal cord, and then they come together and form the nerve. If something happens in one of those roots, one's going to be motor affective and one's going to be sensory affective, right? The more dorsal one's going to be sensory affective, the more ventral one's going to be motor affective. So spinal cord damage is definitely more complex, and the pattern of sensory loss is a little more complex. So for instance, a patient who suffers spinal cord damage at C6 may lose sensation of touch and proprioception in the C6 dermatome and all the lower dermatomes on the body on that same side of the body where the injury happened. If it happens in the spinal cord itself, it might affect both sides. It might only affect one side if it's more over in those roots, okay? And what's kind of interesting too is even if we do have this and it is one-sided, that ipsilateral, the same side, the contralateral might be effective with pain sensation because of the crossover that happens, though usually the proprioception and touch will actually still be fine on the other side. So just a little interesting fact there. So again, just the diagrams, the right side of the body shows the innervation patterns of the peripheral nerves. So the axillary nerve, the radial nerve, things like that. So if a periphery is injured, those are the areas we would expect. The left sides of the diagram show your dermatonal patterns that you guys should be pretty familiar with by now. Okay, next one we have is myofascial pain syndrome, and this is pain that is initiated in the muscle and the fascial linings of the muscle itself. So muscles in a painful area that are dealing with myofascial pain often get very, what we call high-toned, which means they get really tense, and they're usually pretty sore. We've all experienced this, right? Especially the upper traps, all that pain sensation there. Those myofascial pain, that tenseness and that soreness, tend to also be linked to what we call trigger points, the presence of a trigger point that might be activated in the muscle. And what that trigger point is still a little kind of controversial. People are still kind of studying that, but it's a hyperactive area, and it's usually due to maybe kind of a microscopic injury. So not something we would detect, but in that one little location in that muscle, something happened. There was some cell damage. And then what happens? We get guarding. And so that hyperactive area is just a super guarded area that then the entire muscle ends up being affected by. So pain is felt over the large area, but the trigger point is really confined. And so we need to treat the whole muscle, but also treat that trigger point area. So you get that reflexive muscle contraction, and that actually usually then activates the trigger point more. So that guarding that happens activates the trigger point more. We get more pain, more spasm, and we get stuck in that pain spasm cycle that we talked about in chapter 1. Okay, the final pain syndrome we're going to talk about is sympathetically maintained pain syndrome. And what this is where you have some trauma. So it often starts with trauma, usually actually something fairly mild to the soft tissues or to the bones. And either it doesn't heal as well as we would like, or something kind of affects the inflammatory process, and actually the body overcompensates and the sympathetic system of the nervous system gets involved. And so the area reddens and might actually sweat profusely. Those are all signs of sympathetic activation. So if you remember back to spinal cord injuries, and we talked about like boosting and the issues with that, that was a sympathetic response, right, to a stimulus. Same thing's happening here for an unknown reason, not the same thing, but it's a sympathetic response. And so the nerve usually gets blocked. This is usually how we relieve it, by actually injecting onto the nerve and blocking that hyperactivity on that nerve that is overstimulating the sympathetic nervous system. But if the pain continues to increase over time, it can get super severe. And so our job, right, thinking about what we can do, is poorly hearing injuries that show sign of this increased sympathetic activation really need to be evaluated for the signs of this syndrome and should be referred. So if we start to see these signs that the sympathetic nervous system is getting involved, we should really refer them on, because if we can catch it early, it's usually an easier treatment. And in some cases, once the pain reaches those severe levels, no treatment is effective, and they get stuck in this chronic pain. So this is complex regional pain syndrome, is a sympathetically maintained pain, as well as reflex sympathetic pestrophy are also two of the conditions that we can see here.